Hi, everyone. Thanks for joining us for ClearScript's webinar, Managing PBM Trend in 2026, Your Need to Know Guide. I'm Anna Henizelman, VP of Sales for the Southwest region, and I'll be your host today. I'm excited to have you here as we dive into what's shaping pharmacy benefit trends for 2026, and most importantly, what you can do to stay ahead while keeping costs in check and member health front and center. Before we jump in, let me share a quick story about ClearScript. ClearScript was created almost 20 years ago by Fairview Health System. Back then, Fairview decided that they'd had enough of the big PBM's profit-driven approach and lack of transparency. So they built their own PBM, one focused on honesty, cost control, and patient care. That bold move sparked something big. Other health systems and employers wanted the same transparency and member-first approach, and ClearScript grew to meet that need. Today, we're still committed to high-touch service, clear pricing, and better health outcomes. Now, here's what's coming up. You'll hear from two of our experts, Bryan Milbert and Natasha Biermaier. Bryan's been with ClearScript for over a decade and knows the ins and outs of clinical programs and cost-saving strategies. Natasha joined us in 2025 and brings deep experience in clinical review and utilization management. Together, they'll break down what's driving PBM trends and share practical steps you can take to keep your plan strong and your members healthy. All right, let's get started. Bryan, Natasha, take it away.
Thank you, Anna. Next slide, please. Thank you. As far as trend goes, trend has been an issue for a while, and trend is the change in cost over time. The graph below shows just the market increase in trend since the 1990s, and this has really been driven by drug development and new technology, and it's really created or a focus on pharmacy spend where it traditionally was just on medical spend. So we'll go into what has been causing it and what can potentially be done to address trend. Next slide, please. What is driving it? Mainly technological advancements. We have seen the rise of biologic drugs, which are typically proteins, antibodies versus small molecule drugs, which we have known for the past several decades. They're much more complex, but also very effective and can be very targeted. There's also been the rise of rare disease drugs, which address populations of those under 200,000 are affected. Within the United States, it creates incentive to develop drugs for relatively fewer impacted patients, but the cost of those drugs can be very expensive. It's also known as orphan drugs. And also there's been new more effective classes for conditions such as diabetes, where they are, again, very effective, but also much more costly than other traditional therapies have been. Within the United States, there's a special environment that's been created over the decades, such as the rise of specialty drugs that's been defined by pharmacy benefit managers. Specifically, those are very expensive drugs that require additional handling and support. New drug classes without generic alternatives. We really rely on generics to help keep costs down. We have a new class. Generally, those classes are dominated by very expensive brands until the patent expires. We have the Orphan Drug Act of 1983, which Congress has established incentives for manufacturers to develop drugs for relatively few people. And also there are patent extensions, which expand the scope of potential clients or patients for drugs. And also manufacturers create what's called patent thickets, which are very difficult for generic manufacturers to penetrate and launch their own generics. Another driver is our aging population, and again, label expansions increases the potential pool of utilizers of expensive drugs. Next slide, please. The changes that have been put into place or controls to address spend, pharmacy benefit managers have utilized since the 90s, where it really has become a pretty steep slope of increasing prices, where again, the designation of specialty drugs, where they're treated with their own classes or own tiers, and then where benefits can be tailored to specialty drugs and these expensive products. Specific utilization management strategies, rebates for these all brand classes have become a major source of cost offset for plans, and also cost control and shift programs such as copay maximizers is a way to help defer costs to plan sponsors. And then the plan sponsors themselves have created benefit inclusions and exclusions, such as they exclude weight loss, so on and so forth. And then you have stop loss coverage, which many self-funded plan sponsors have elected to protect themselves from, especially those rare disease and orphan drugs. They also utilize 340B if they're 340B covered entities, which help offset cost of these expensive products. And then some decide whether to go potentially fully insured if they feel that the potential risk exceeds what their resources would be. Okay, next slide, please. And currently, since those first controls have been put into place, trend is still an issue. There's, as we mentioned with the technology, ever new technologies and classes have been created, and those drugs have launched. So that has not slowed down. But the advent of biosimilars have also added generic like competition to these biologic drugs, which has helped. And then again, growth of the 340B program, especially in the past 10, 15 years of the use of 340B contract pharmacies, that has helped some plans control spend. But it's still a concern. New drugs and expanded indications continue to drive trend. And with pharma manufacturers, they tend to focus on the specialty category, specialty drugs, high cost conditions, and also the increase in rare disease drugs, where treatment can cost hundreds of thousands a year for potentially one member. So that has been and continues to be a challenge for both PBMs and plan sponsors. Next slide, please.
All right, so I'll take this one. So biosimilar drugs, they've been a hot topic for a couple of years as Humira and Stelara and others have been launched, but it's something we continue to see as a hot topic for the foreseeable future. More interchangeable biosimilar drugs are expected to be launched in the next 10, even more 20, 30 years. We know it's going to continue. So want to talk a little bit about the different strategies that we have and we use to manage these really potential savings for our clients. We have two different types of strategies, and they're formulary strategies. So there are other options, but this is our standard formulary in the way that we manage these medications. We have a single phase approach and a multi-phase approach. The single phase is when we are able to move directly to preferring and covering only the lowest net cost biosimilar and not covering the brand originator once these biosimilars come out. This is typically done when there's less financial risk in this type of a more aggressive strategy, and there's maybe lower utilization of that originator brand. So we don't have to worry about, certain number of people staying on the brand and, not getting rebates, having a higher cost with that. With medications that have a higher financial risk, because maybe rebates are really high on those brand originators, or there's a lot of utilization of those medications, we go through the multi-phase approach. And this is where initially we have the brand and the biosimilar co-preferred for all users. Then we go to the next phase where the lowest net cost biosimilar is the only option for people who are new users. And anyone who's already on the brand name is allowed to stay on that for this phase. Then when we get to the third phase is when we're able to, be confident we're going to move enough people over to that biosimilar to really see the savings and not have as much financial risk. And in this phase of this approach, we only prefer the lowest net cost biosimilar, and the brand name is then not covered and not preferred. ClearScript does have additional support to help move users to biosimilar products, even during that multi-phase approach when they're co-preferred for the brand and the biosim. We have a really close partnership with Fairview Specialty Pharmacy, being that we are part of Fairview. And through this, we're able to really support our members and help them through the switch. The pharmacy staff over at Fairview Specialty Pharmacy works really closely with the members to, communicate what the change is, why the change is, and what it means for them. And we can work with them very closely to communicate, who has switched, who hasn't, where each person is in that process, so we can keep a close watch on what's happening with that conversion. We also can support setting up a benefit exclusion, and this is to omit the brand when an interchangeable biosimilar is available. This would be done via a benefit update and through the SPD language. However, this is really dependent on rebate contracts and the financial risk for the medication, so it's really drug dependent on if this is an option. There are a few considerations for which strategy the formulary follows, and recommendations are based on these different considerations as far as if we would follow which phase approach, if it's a single or multi-phase, or what we would recommend for benefit setup changes. Some of those considerations are the net cost of the brand name drug versus the biosimilar, and what amount of people, typically a percentage of people we would need to break even or not lose money on anyone who stays on the brand when the rebates are taken out of the picture. We also look at utilization of the brand name drug and the amount of people are using it, and we would need to have move over. If you have one person using the medication and we're confident we can get them switched over, that's an easy decision. But if it's 15 people and we know there's a couple people that just from past experience are going to have a hard time switching over, that's when we're going to be a little bit more hesitant, because we don't want to lose rebates and in the end be spending more with the different approach. And then we also look at the access of the biosimilar drug to ensure that people have access to whichever drug is covered. So if we go through that single phase approach, we want to make sure that that biosimilar is going to be available for people who need it. All of these strategies require compliance with the formulary and the benefit. Once the brand is no longer covered on the formulary or through a benefit exclusion, the rebate loss and any fills resulting in that can be a really high cost to the clients. All right, next slide. So LDD, this is limited distribution drugs. They are a piece of the specialty spend that can contribute to really high spend. They're commonly used for rare diseases that Bryan touched on, and they are required to be filled at a specific pharmacy or sometimes multiple, but it's really narrow in where these medications can be filled. So they might have to go to just the one pharmacy in the country that can fill it, through mail order, or if it's a number of them. This really limits our opportunity to control and address the costs on these medications, but there is some opportunity with a couple, so far definitely one drug in here that has the LDD brand name, but there's a generic that's widely available and not required to go to that single or couple pharmacies that are limited distribution. We do have some strategies when we can identify this to help manage the drug and help update the plan documents and benefit to exclude the brand name only when that generic is available. This allows the plan to utilize the less expensive generic over that brand name and negate covering the DAW1 when it is available as a generic. If we can increase the internal capture and enable 340B for our clients, that's going to definitely help out on savings and spend overall. So that's something we can also do when we look at narrowing in on that generic for these situations. One example here is Korlym. This is a brand name limited distribution drug, which is really just limited distribution due to the risks of using it during pregnancy. Teva recently launched a generic equivalent that is widely available, is not required to go to limited distribution, and is something that we are seeing an opportunity in allowing us to drive any of these Korlym users to a generic, which can be filled at even an internal pharmacy or other retail pharmacies. We can go to the next slide. Another area we have seen as a potential for savings is the networks. So the pharmacies that are allowed to fill medications for people. Big box pharmacies offer member convenience. They're oftentimes just down the street, but they also charge more than other pharmacies for the same drug. It's most evident on certain generic medications. We can start to look at narrow networks as an opportunity for savings, but we also need to weigh that member impact on convenience. This is the most aggressive way to manage a pharmacy network by only allowing grace fills and restricting all maintenance medications to non-big box or a narrow network. But there's different ways to do this by allowing grace fills or also having the mail order to make it a little easier for the patients. You can also set just a higher copay at these big box pharmacies to steer people away from the CVS, Walgreens, Walmart, but still allowing people to go there if they need to for convenience. We can also send out letters to members paired with either strategy to encourage people and support people in moving them away from those big box pharmacies, trying to help move people over to these smaller independent, grocery stores or even the Fairview retailer mail order. Those are different pharmacies that we've seen having lower costs on the generic medications. Mandatory mail is another option, but it really is dependent on your members and what is right for them. Some things to consider in moving to a mandatory mail is, using targeted letters to encourage people to use mail order before making it required to see what number of people we can move over to the mail order. We can use mandatory mail for maintenance meds and then allow, a certain number, 2, 3 grace fills at any in-network pharmacies so people can go to Walgreens or CVS for the first few fills of their medication before they move it over to mail order. That also allows people to get comfortable on a new medication rather than having to go straight to mail order. We can also pair the mandatory mail with any client-owned pharmacies. So if a client owns a pharmacy on site and they want to try to drive people there, they can do that paired with mandatory mail, and that can help move people to their own pharmacy. Some things to consider when thinking about mandatory mail are the number of people currently using mail order and how many maintenance medications are out there that are being filled at other pharmacies. And then again, looking at if you have an on-site pharmacy, how many people are using that and how many people are maybe close enough to use that pharmacy so that we can consider that over mail order. Okay, next slide.
All right. Thanks, Natasha. Just want to cover one thing that we have been seeing that's been driving some trend with some clients, especially with the growth of the GLP-1 medication specifically to treat diabetes, is that, and also with the growth of popularity of high deductible health plans, that sometimes that their legacy benefit setup has caused some unwanted surprises from a spend standpoint. So I just want to take this time to just give an overview of preventive benefit offerings and what is mandatory and what's optional, and just some things to keep aware of to prevent unwanted plan spend where you didn't expect it to be. First, I want to cover the Affordable Care Act's $0 essential health benefit. So these are defined by the U.S. Preventative Services Task Force. Relatively small list of drugs. Example would be oral contraceptives, breast cancer prevention. These are preventive drugs that are deemed most important, and it's also required for even private plan sponsors to cover these at $0 cost. Again, defined by the U.S. Preventative Task Force. So those are generally a given as part of your benefit. Optional benefits are, we call those like a general preventive benefit offering and then a high deductible safe harbor. High deductible safe harbor is that for the high deductible plans, which typically you need to hit your deductible first before the benefit would kick in, these particular drugs on this list, and the scope of the drugs can vary. It can be more subjective than the $0 essential health benefit, but generally the same categories and potentially a few other clinical categories as well. And this goes beyond what the essential health benefit is. What the safe harbor does is that it waives the need to meet the deductible first before the benefit kicks in. So we call those drugs receiving first dollar coverage. We have seen some clients elect to have a safe harbor preventive benefit, but the benefit on those high deductible plans was set to $0 cost share once the deductible has been met. Of those drugs, especially if there's GLP-1 medications as part of that safe harbor list, all those members with high deductible plans are paying nothing for those GLP-1s on the first day of the plan year. So that's something that we've advised clients to make sure that if you do have high deductible plans, if you do want to have a safe harbor benefit, to make sure that you have adequate cost share once they hit the deductible. So as we have clients that ask about, should I do it, should I not? It's really optional, but you just want to know what that entails. General benefit, the general preventive benefit is also optional. That applies to also copay plans. And generally, plan sponsors set the copay lower than it would be typically for those particular tiers. And again, another important call out is that you want to be, you typically set to be lower than the standard copay tiers, but don't make it excessively low where it can really drive excessive cost. And also, if you want to elect a preventive benefit, talk to your account team to review the list of drugs. You may even be potentially able to just cover the generics within those classes. So that's another way to keep costs lower, but still offer preventive benefits. So long story short is if you want to explore offering preventive benefits, to know the difference between the offerings and also to know what drugs are included and also what your benefit setup is before you actually go live with those changes. Okay, next slide. Okay, so we've reached the end of the major issues that we've seen driving trend and some of the more nuanced approaches that you can take to controlling trend. I just want to touch on the main recommendations that we have for clients is you want to be familiar with your benefits setup because like to say that while the formulary and the is more like the computer hardware, it's your benefits setup and your SPD that really are the operating system that really drive how your benefit actually works. And as you want to review your setup, talk with your account team, if there's formulary changes or if you switch to a new PBM with a new formulary, just to double check and ask them, do my benefits work in concert with the formulary and the tier structure? Does it make sense? Because a lot of times if you move to, if you convert to a new PBM, the formularies are different and many times your legacy benefit setup may not be compatible. And again, you want to recognize conflicting setups, as we've mentioned with the high deductible plan with a $0 cost share and safe harbor. That's a conflicting setup, so you want to make sure that those are resolved and things are working in conjunction with each other. And also, you want to review your member plan cost share ratio over time. With the increase of specialty drugs and high cost drugs, you tend to see that cost share erode. Traditionally, a lot of plan sponsors like to shoot for a 20% member, 80% plan ratio, but as time goes on, especially if you have a set copay dollar amount, that share tends to erode. So, discuss with your account team to say, is it time? Does it make sense for us to change the copay structure? If you switch to a co-insurance percentage, that tends to keep pace with with the total cost of drugs, and it's self-adjusted because it's a percentage. So that's something you may want to explore with your account team, and just, does it meet my needs for the next 1 to 2 to 3 plan years. So I want to hand it over to Natasha to cover the summary plan document.
So something with the summary plan document to keep in mind is what different benefit elections you have. Make sure you're looking at the formulary like Bryan mentioned. And, I think Bryan once has said that it's like a buffet. Everything on the formulary is your buffet, but then you want to look at what are you putting on your plate? And that's your benefit selection, is what's on your plate that you bring to the table for yourself and others. I thought that was a really good analogy and I wanted to use that here. And definitely look at when it was last reviewed, when it was last updated. Talk to the account team about, based on your specific drug spend and drug trend, what creative solutions can we come up with for you? It's definitely something we look at each client to come up with, a couple of creative ideas and make sure that we're really managing your drug spend and trend and not just, our whole book in one. So definitely talk with us and we'll come up with ideas to help you.
Yeah, thanks, Natasha. Yeah, again, it's important because every client's different, population's different. Some drug categories are driving spend in some populations versus others, and there can be different approaches, and it depends on what resources certain clients have at their disposal, whether you're a critical access hospital, a health system, tribal entity, self-funded commercial payer. Depends on what resource you have in the area. So we like to really look at all possible avenues for correcting your spend and trend, and also just to be creative and meet your specific needs and specific goals for your pharmacy benefit. All right, next slide, please.
Well, thank you, Bryan, Natasha, for those great insights. That was great information. Thanks to all of you for joining us today. We hope that you found this very helpful. We host webinars and podcasts every month, so check them out on our website or follow us on LinkedIn. If you have any questions or ideas for future topics, reach out to me at any time. Thanks again, and have a fantastic day.